So, hello everybody. Welcome to the next session of the Virtual Global Spine Conference. I'm Alexander Mameghani. I'm usually broadcasting from Switzerland. Today I'm broadcasting from France. And I'm very happy that you're participating in this conference late at night here, or 6 a.m. The Eastern Coast. And I really am glad to be not here alone. Andrew is here. If you want, I would love that you ask questions to me about the cases I'm presenting today. So I will start with the first case. These are my disclosures. Nothing to do, nothing related to my talk today. So the first case is pretty easy and pretty difficult at the same time. The patient is 82 years old. This is a little bit above the average of my patient's age, which is 77 in the DGen population. He's 82-year-old male, he has got many comorbidities, and he's suffering from a pain. It's really not a back pain. He always says, no, zero back pain. It's only the leg, the right leg. And this is the MRI. You can see here the sagittal T2. And I was just highlighting here on the left image the foraminal stenosis L45. And this was my thought when I was examining the patient, listening to his story. This is maybe symptomatic foraminal stenosis L45. But you see, the X-ray shows you not more than a foraminal stenosis. He's got a flat back. He has got some coronal deformity, mainly in L45. And you see the right side is a lot narrower than the left side. This is a little bit a close-up view. And I'm just asking you, what would you do? I think we have got several options. Multi-level stenosis for sure on the MRI, but maybe it's only a foraminal stenosis. Do we have to treat the coronal deformity? There's a lot of osteoarthritis in the facet joints as well. Small herniated disc L45. I show you again here. You can see on the right side a little bit. The disc material is extruded from L45 and is going caudally. So the medications I put here, you see, he's diabetic. He takes a lot of NSAIDs like diclofenac or ibuprofen, which is not good for the kidneys. And if you have a look at his blood sample, there's not really a parameter which makes you happy. So may I ask you, what would you do? Do you do multi-level decompression? Do you use your fusion devices and say, okay, this coronal L45 thing has to be fused? Or do you need more information? Andrew, may I ask you, what are your thoughts?
Yeah, so these cases might not be technically the most demanding, but I think these are some of the hardest cases to decide what's the right thing for the patient. I don't think I'm going to do a very good job with a decompression alone surgery for this. I think the disc space, height loss, it's contributed to that foraminal stenosis. So I think if we're going to treat this surgically, it's going to be a fusion for me. It's probably going to be an L45T lift. I think I would probably select any more information. I want to make sure that the patient's not osteoporotic before I decide to do that. This male, so less likely than females at this age range, but he's 82, so I'm going to want to know that before I commit to using it.
Yeah. What kind of information would you do in your practice? What would you order? What would you do before you take the patient to the OR?
Yeah, so I do a couple of things. I do get DEXA scans. I think There's more and more information now that maybe grabbing console units from a CT scan is probably as good, if not better. I still get DEXA scans usually in my deformity cases and my elderly patients. So I probably get a DEXA scan. I get hip and wrist. The spine gets from degenerative, from osteophytes, from scoliosis, gets artificially elevated on DEXA scan. So I get a DEXA hip and wrist. And then we have a preoperative anesthesia clinic that I typically send essentially everyone in, except if they're like a healthy 20-year-old, where they get all the preoperative workup, just make sure that they're healthy and not going to have an MI.
Yeah. So very nice. You mentioned the CAT scan. Do you send your patients to neurology and ask whether they can identify whether it's L4, L5, L3? Well, is there a value in your daily practice, or do you skip this interdisciplinary approach?
I do sometimes. I've found, at least at our institution, it's been not super helpful. I find a lot of times I'll get an answer like, it's L4 to S1 radiculopathy, or just kind of a more broad sense. I'm looking for, they can tell me this is L4, this correlates. But the number of patients that sent over there and the number of times I get like, oh yeah, this is definitely L4. Not as much as I'd like. So I think if it correlates on my exams, if it correlates with the symptoms, the distribution that they're telling me the pain is, that's what correlates on the MRI scan. I usually don't, get an EMG, but if I'm really scratching my head, I will get them. Honestly, I use EMGs more to like rule out radiculopathy where I don't think it's a radiculopathy. But I think it'd be reasonable to get to try to see if this is impactful.
Yeah, I'm not a fan of extensive neuroelectrophysiology, because when it comes to multi-level and then finally it's L5, I still don't know whether I do only have to do L5 as 1 or 4-5 or even 3-4 as well. So, but I see a lot of transfers to neurology in private practice. So my colleagues are very frequently transferring their patients in a routine fashion to neurology. And this always makes me wonder why. Maybe it's only cooperation. It's like a win-win situation. I don't know. I'm a little bit more confused by neurology sometimes, especially when the answer is there's no chronic denervation. There's no sign of any neurocompromise. The patient has really a severe pain syndrome. So I ask you the same question again: multi-level, single-level fusion. So Dr. Grossbach, he's an orthopedic surgeon, aren't you?
Neurosurgeon.
Neurosurgeon, okay. So I love it. Now I'm an orthopedic surgeon, and I voted for 4, and I went over and did an endoscopic foraminectomy. So I show you, this is what me, an orthopedic guy, learned in the last years, a couple of years, and it's pretty hard challenge to learn this, but patients are sometimes really happy. So you see from the right side, come with a endoscope transforaminal approach. You see the burr now, it's a diamond burr, very small, very tiny, in my point of view. And it's very slowly approaching the foramen. You see, stepwise, I get into the foramen. I have to drill away a lot of osteophytes and lateral aspects of the superior articular process of the SAP. And then finally, I'm in the foramen. Here, I'm taking away some ligamentum flavum, which is accessible via the foramen. This is the lateral view. And finally, the patient was treated endoscopically. You can see here the superior articular process of L5 is missing. This is only the bony resection. Of course, I'm resecting the capsular and the the flaval ligament as well. And you can see on the axial view, the line, there are some debris inside, next to the lamina. This is the rest of the osteophytes. This is the post-op image. The coronal deformity is still present. I didn't touch it. It was not changed at all by the surgery. And this was pre-op. And if you compare pre-op and post-op, have a closer view, you can see here what I've taken away. Counting is very easy. Here you see L45 is the one with the right narrowed foramen. And this is the bone I took away just to get into the neurophyte. Now you can say, oh, I'm taking away the pillar, the bone that stabilized this segment. But I think it's a pathological bony formation. It's nothing to do with stability. And these stenosis and the foraminal stenosis can be treated with this endoscopically approach. So this was my solution for this case. I ignored the flat back. I ignored the coronal deformity. Maybe the patient comes back. Maybe he needs a fusion surgery. I cannot tell you, but I have less blood loss. I have less length of stay. The diabetes, all these comorbidities have not such a negative impact on the outcome like in open or minimal invasive surgery. This transforaminal endoscopic lumbar decompression, abbreviation is TELT. I would not have been able to present a case like this 5 years ago. So this is a pretty new technique for me in my hands. I still take much too long time for these stenosis to decompress stenosis. I wish I could do this in 60 minutes or 75 minutes, but I'm still over 2 hours. And when you compare with your fusion skills, I guess many of you are faster than 2 hours. But time is not the most important factor. I think it's less invasive than any open approach. And if you can free the nerve root with this technique, I think it's a good solution for the elderly patients with comorbidities. Do you want to comment on this before I go to the next case?
No, I think this is a fantastic procedure for this problem. I haven't added endoscopic foraminitis to my repertoire yet, but I think this is a great case for that. I mean, worst case, they don't get enough better. You always have a fusion, but rather than jumping into a fusion with an 82-year-old comorbidities, I think this is a phenomenal surgery for that. So,
yeah, it is. I told to the patient, I said, this is just an attempt to help without fusion surgery. And nobody can be sure that this is successful enough for 10 years or 15 years. We just talked about the risks of surgeries and what is the goal. And this procedure would not work when there was a big back pain. So if there was back pain, I think it's not very wise to go for a single level foraminotomy. So you have to choose your patients carefully. So the next case is a much younger woman. She has bilateral radiating pain, but only when she's walking. So she sits a lot, as you can see. She has a moderate back pain, not too much, maybe because she's sitting a lot, and she has no neurodeficit. This is the MRI. And if you go a little bit to the parasagittal line, here you can see a cut through the facet joint. Again, it's 4 or 5. and on the other side as well. And this is the actual view. Andrew, Dr. Rosbach, what would be the next question you have?
So I see all that T2 hyperintensity in her facet. So I want to know if she's got instability, which I think this to me means that those facets are unstable, but aren't for those measures.
Yeah. What is the next examination you would ask your residents? What is meaningful? What is a great value?
So was there a sagittal view?
So this is the mid-sag. This is a little bit parasagittal, and this is the actual view. You won't find any actual view with more compression than this. So the spinal canal is free. There's no compression.
I want to see some upright X-rays. I usually get flexion extension views, but I think supine MRI to an upright X-ray usually tells me as much information as I need for.
So I give it to you. So this is so hard to identify here. I don't know whether you can examine L4-5. I can zoom in a little bit. So this is a little bit zoomed in, and you can see a slip L4-5 very easily. And the BMI is 42. I guess it's not really 42. It's a little bit higher. But she said that no, this was her actual weight. Maybe it's 45, 48. So my question is to the audience, what are you doing in a case like this? Everybody says,
Alex, it's Mike.
Hello, Mike. Mike Selby from Australia.
Can I make a point on the MRI you showed before? On the axial slice? Yeah, if you go back to that, couple of things. And look, I agree with Andrew 100%, but when I look at an MRI of a patient like this, there's the obvious facet of fusions and potential instability, but you look at that patient's multifidus as well. You look at the quality of their posterior spinal muscles. I presume they haven't had past surgery there. That is not normal, what you're seeing on that patient's spine. Those muscles are not that functional. The multifidus is completely replaced by fat at the L4-5 level. Now, that can be a bit more normal to see a bit of marbling at L5-S1, but you don't want your back muscles looking like a Wagyu steak, right? And that is really bad in terms of prognostic indicators as well. There's been some work done on this. So basically showing that if you do a laminectomy on these patients only, or a decompression, just say there was a bit more stenosis, they don't do well. The question is, do they do well with an isolated fusion procedure as well? And I don't think that's been completely answered. So looking at that part of the MRI, as well as your anatomical approaches, I think is really important when you're assessing these patients in the clinic.
Oh, thank you very much, Mike. I love this mentioning the bad muscle. Would you offer these activators, the stimulators of the multifidus placed at L3? I know you did some cases. You've had a talk about this.
Look, I think in the presence of that degree of motion between, L4 and L5, a reactivate here would be challenging to get to work. Probably not the ideal patient as well, with, I think you said, some features of radiculopathy going below the knee. We tend to avoid reactivate for those cases. I mean, the main indication for the device remains chronic axial lower back pain with an element of multifidus instability, and clinically and then radiologically, sort of some wasting being present, without frank neural compression, or clinically without neurological pain radiating below the knee. So I think you can consider it as a sort of prehabilitation option, which is getting a little outside its initial indications. Something that we've been doing a bit of in terms of deformity surgery. But I think this patient, I'd be a bit hesitant to offer a reactivate to as the primary treatment.
Yeah. Just want to explain for the audience, Reactivate is a stimulator, but it's not a neurostimulator, it's a stimulator for the muscles. It's placed at L3, only L3, and the bilateral electrodes are stimulating the muscles like a TENS, but it's not transdermal, it's an implanted. And the patients make their exercise, I think, twice a day for 15 minutes, isn't it?
Usually 25 to 30 minutes twice a day, but people will vary that regime. But that's the standard advice. Some people activate 3 times a day, some people do once a day. Yes, the leads very much just go over the transverse process, targeting the medial branch of the primary posterior rami L2-3. So they're not going in the spinal canal at all.
Yeah. So I go for here. I think we have to look whether decompression only or fusion single level is a solution, or in between is weight loss mandatory prior to any spinal procedure. I know obesity is a big problem in the US as well. Do you have a standard algorithm, Andrew, or Mike in Australia? Do obese patients have to undergo a step-by-step algorithm until they are able and able to be a patient for the OR?
So unfortunately, I don't have a standard algorithm because, obesity is a huge, huge problem. In Ohio, it's a huge problem. If I didn't operate on people in BMIs in the 40s, I'd be out of business. I've tried. The problem with bariatric surgery is the process is it's a long process. There's neurocognitive evaluations. There's multiple visits. It's a years-long process. And then having patients just telling them, okay, lose weight. If their back hurts, if they have instability and they're not able to exercise and not able to walk. So I do a lot of aquatic therapy for my patients. In the pool, it takes a lot of stress off the low back. Let's do a little bit more. But really seeing a meaningful BMI reduction. So in my talks, I tend to half jokingly, half serious call a BMI a non-modifiable risk factor, because the number of patients I see that have a meaningful reduction in their BMI is very, very few. So I don't have a strict cutoff. Everyone's trying to put these risk factors into things that are objective, but there's a subjective component to it. I walk into a room, after COVID, there's a lot more virtual visits and televisits and stuff like that. I like in-person visits because I can walk in and I can look at a patient and I can say their BMI may be 43 or 45, but don't want too bad, or maybe it's 45 and it's like where they carry their weight is going to make it extra difficult to heal from. So I don't have a hard and fast cutoff. It's a very individualized thing, and it's a conversation you have to have with them. If your BMI or whatever, your infection rate's going to be up, your osteoarthritis subsidence rate's going to be higher for fusion surgeries. So yeah.
Yeah, I forgot to mention the BMI of the first patient, which was very low and has had foraminal stenosis. And I think pain is always subjective. And it's hard to let the patients with obesity undergo a program which mainly is predictable to be not successful. So this patient, we talked a lot about her obesity. And I would love to the audience to use the chat box. Would you offer surgery or would you refuse to offer surgery? Because the patient tells me that there was no single diet that has ever worked. She was obese since a child. In puberty, she was always obese. The whole family is obese. She said she would not undergo bariatric surgery because another family member underwent and it was not successful. She tried this substance, liraglutide. I'm not an expert in these substances, but it's not Ozempic, it's not Wegovy. It didn't work. Whatever she did with physiotherapy, exercise did not work. So she is a happy eater, and she is not binging, but she eats the sweetest things, and we have a lot of sweet things here in Switzerland. So, what can I offer with these facet joints? As Mike Selby mentioned, to decompress here a little bit, will this help the patient with the bad muscles? I'm not sure. So this is iliac crest, and when I mentioned the iliac crest here, I guess you have a thought what I have done. So I did a lateral approach, did a lateral interbody with a titanium cage filled with bioactive glass, and added a posterior fixation. This was not correct, not me did it. My attending, Dr. Mendelovich, did it, and he did a really great job. Patient didn't have any problems due to the excess, so no pain in the thigh, no neuropathic new pain. She was very, very fast on her legs. She was ambulatory within 2 days. We don't do these ambulatory here. It's always an inpatient setting here. And he placed this cage very nicely. You can see now the facets are still distracted. We won't get a solid bony fusion here, I guess. So all this fusion mass is inside the cage. Would love to hear whether Mike Selby or you, Andrew, put more putty or more substitute or more fusion enhancers anteriorly of the cage to enhance the fusion to the mass. But this is my this is our L45 lateral approach. It's just lateral. I don't call it OLIF or XLIF or something else. It's a direct access. It's transpsoas. It's minimal invasive. This is the reason, because I think that this lateral access is it's a better option when the patient is obese. When I look at the estimated blood loss, the OR time, so my attending Itai Mendelovich did really great, and I think this was a good solution for L45. The patient is happy, but beware of the bias. When we do surgery too aggressive in obese patients, maybe we will have a decline in our outcomes because of bad selection of these patients. And when we look into the literature, some like 15 years ago, William Rogers and Gerber published quite big series of extreme lateral access procedures, and they didn't find any complication due to obesity in this kind of approach. And I think this is quite interesting. And this paper, when it comes to obesity, should maybe save this, because it's very often cited, and it's nice that that we have this data. Does anybody want to comment on this case, or otherwise I would proceed to the next case?
I think it's a great use of the lateral interbody for this. I think, you know, these patients, you're gonna have higher rates of subsidence, and so you can get a big cage in there. And then I think the other thing that, you know, lends well to this versus the TLIF is the disc height. You know, if you're that disc height, even though it's unstable there, it's very tall, and trying to sneak in a super tall TLIF cage is not always the easiest thing, especially in obese patients. So I think it's great use for this surgery. It's really good.
Oh, thank you.
Alex, I think that this is
Yeah.
great. It's a great solution. Couple of quick comments. I probably would have done
Yeah.
the same thing 4 or 5 years ago. Now, if I felt access was appropriate, I'd probably do it in the prone lateral position. I do almost the same operation in the prone lateral position. However, in that position, it's a bit easier, particularly if you're putting the screws in laterally for this. In prone lateral, you can get a burr and you can easily decorticate those facet joints and pack them with graft at the same time as you're putting in your MIS screws. So it just adds an extra bony area for fusion.
Yeah, I think this extra area for bony fusion is really good. I'm looking for any implant that could be inserted in these facet joints, like a wedge or something like this. But it's
there
not
are some
available.
little facet cages available, but they're not. Yeah, I've used them a couple of times as salvages. They're okay, but they're not that practical. And then the second thing, I suppose, and it'd be interesting to hear Andrew's comments on this as well, but there's been at least one paper recently, maybe I've seen a second one, that's shown when patients have L5 foraminal stenosis and you do a fusion at L4-5, I think it was particularly with TLIF and PLIF, the outcome is not as good long term as if they don't have disease at L5 foramen, at effectively the L5S1 disc height has dropped. Now, I did see in this patient that was a bit of an issue. And I'm not saying you need to routinely fuse 5-1, but I think we have to include that in our sort of patient consent and discussion, because it does sound like this patient's done well in the short to medium term, but I think you have to look out in that medium to long term for these cases.
Yeah, it is. I didn't mention this, but in this patient as well, L5S1 is not unsuspicious. You see, it's a very narrow disc, but there's some. It's not a real hernia, but it's an extrusion of the disc. The foramina are not so wide. And the discussion we had is whether we go for an ALIF and restore some more lordosis. But then on the other side, we were pretty convinced that L4-5 is the main issue, and the segment where the problems are coming from. So we skipped the L5S1, but we always discussed this in our team. So I skipped to the next case, and this is the case, again, elderly woman, not too old, she's pretty active, and she has got a right leg pain, even when she's resting. The worst is in the morning. After a bad night, getting up is an extra pain. And no, she did everything, but nothing helped. And she's known for a severe osteoporosis since years, and her actual T-score is still -3.8. And she got all this stuff. So this is the SEC2, and this is the steer or the turn sequence. And if you look the actual view, you can see this formation coming on the right side from a joint. We were a little bit guessing, is this 2-3 or is this 3-4, where the cyst is coming from? I said it's 3-4, not 2-3. So this is another actual view, and I can go on. Here you can see nicely the effusions. But the patient really didn't have back pain. She only has a right leg pain. And this is really on a severe scale. It was like she was at 9, 8, 9 in the night. Sometimes she was crying. She was really telling that the pain is pure torture and she couldn't escape. So this is another couple of images, you can always see every facet joint, not only 3-4, has got effusions. So everything is here with question marks. Say everywhere are questions. You can see a slight slip in 3-4, a nice lordosis, a known severe osteoporosis. This is the AP view. And my question to you, to everybody, is what will you do with an 82-year-old patient with a cyst, with a slip, with effusions, but no back pain? What are our options? Is fusion an option we would choose? The osteoporosis, even with 40 with teriparatide, was still bad. And again, I want to ask everybody to use a chat box whether decompression only is a good thing, or do we have to add fusion? Does anybody want to jump in and answer this question I had? So I just go on and I tell you what I did. This was pretty the same year when the Norwegian study was published in the New England Journal of Medicine, that if there's no foraminal stenosis, decompression alone can be very helpful. And fusion is not adding so much value to these patients, despite more blood loss, more OR time. So I did only do a decompression only. And this patient was very, very happy for 6 months. And then the leg pain came back. It was not so severe. You can see here the effusion from 3-4, some foraminal stenosis now, bigger present than before. Maybe a little bit of intraforaminal hernia as well. You can see here on the axial, the central canal is decompressed. There's no central cyst anymore visible. We were not facing the same pain like before, because the nights were good now. And so she could sleep, she could find her rest, and only when she was walking, the pain was present. So we did an epidural steroid injection, transforaminal, and the patient said that the pain is acceptable for her for 1 year. And after 1 year, she came back with bilateral pain. And now we are facing 1.5 years after the prior decompression. And the pain is worsening 1 week after this MRI. And you can see here the cyst is back. Here on the right side, the foramen is very narrow now. You can see here the central canal is still free on this level, but here we have now 2 cysts, one from the right and one from the left. I would love to ask Wendy Gibbs what is inside the cysts, and why is the cyst on the right side more proteinous than on the left side? Is this due to the surgery, due to prior surgery, or is there an hemorrhage? Because when patients have got a sudden onset of pain, we know these cysts they can have a bleeding inside the cysts, and they appear like chocolate cysts when we open these. So before we talk to what to do, you can see here the new X-ray with a fracture of L4. And this happens after the MRI and before this X-ray. Here you can see a split component. Now we have got an L4 fracture as well. So T12, by the way, is a new fracture as well. We've got bilateral cysts. What can we do now? What can we offer these patients? It's very, very severe pain. And we have still a nice lordosis. and still bad bone quality. I would love to hear how big is the instrumentation? What would you offer? I think everybody will vote for decompression, maybe direct decompression. I don't know whether you would choose a 3-level lateral access or 1-level lateral access with this L4 split fracture. These were my thoughts. What can I do to help these patients? You're not familiar to German, but this L above here on the X-ray, and this here, oh, sorry. No, I ruined it. And this here is a fracture. Here we have L4 fracture, and here it says lying. So patient couldn't get up. She was not able to walk. Andrew or Mike, are you able to jump in and ask what would you have done in this situation?
Yeah, it is a very tough situation. I mean, obviously, I think the original surgery was fantastic. I would have done the same thing, decompression, not jump to a fusion in a 2-year-old right away. I think this is, you know, at this point, cysts come back, spondy, you know, then it's fusion time. Obviously, the osteoporosis is a complicating factor. A slide or two ago, I was thinking, oh, they've been on treatment long enough, it shouldn't be an issue. But obviously now, with new fractures at L4, new fractures at T12, obviously osteoporosis is still an issue. So if you're going to jump into fusion, you need to do something to help augment, cement augmentation, something like that. And then it also takes away. This was a L3-4 fusion. I think lateral or TLIF would have been great for this at L3-4, but now with that L4 fracture, that takes that away. You gotta span across that. So you have to do a larger instrumentation now. Probably using cement for the osteoporosis that is obviously still an issue with these ongoing fractures. So it becomes a bigger surgery, obviously. So it's a tough situation.
I think without cement would be a right direct into hell. With cement, it's getting a little bit much safer. But sometimes I go into surgery and I definitely know, okay, this is the least wrong surgery I can offer her. It's not the best surgery, because we always have to face that in this age with this osteoporosis, any construct has got a higher risk to fail. Not a failure rate like we know from the literature, like 10-15%. This immediately rises up to 50-60% failure rate. And I told her we have to fix the problem L4, the 3-4 now. We have to make the construct longer, but this will not be the last surgery for you. And she knew this, and she accepted this. So I did this. I did cement augmented TLIF. I went 2 up to L2. Then I went to L5, and I left L5 as 1 below, and I didn't cross the junction, didn't stop at T10. So I did the least shortest construct that made sense in my opinion. I was thinking about stopping at L3, so the upper instrument vertebra would be L3. Intraoperative, this bone quality, this weak bone, made me change my mind, and I added L2. So this is the post-op CAT scan, and the patient was fine. After 6 months, she came to my clinics. She was fine for a couple of months, and then she was suffering from a new pain in her groin, and it was really a sharp pain. It was only on the left side, And when we look to the image, we see some end plate fractures. The PJK, as expected, occurred. And so she said she doesn't want to have any open surgery, no extension to T10, as I've told her. She asked me whether there's a small solution, whether I can sacrifice the nerve root or something like this, not a construct bigger, to make it bigger, to deconstruct anything like this. We were discussing about a stimulator, but if you've got an ongoing compression, these stimulators don't work very well. They work for a couple of weeks and then the pain comes back because the compression of the nerve root, this intraforaminal compression, is not solved. And now I want to show you what I did. This is maybe unusual for you, but I did a lateral approach again, like in the last cage, but it was a stand-alone lateral procedure. I inserted the cage as usually, did the excision of the disc as usually. Of course, I felt it was a little bit soft, but it's only in the middle soft of the lateral where the end plates are. The apophyseal region was pretty good. So I was able to insert the cage, and then I added one screw in L1 and one screw in L2 from the lateral side, as you can see here on the CAT scan. And as these screws are fenestrated, I was able to augment these with cement. This is the cage. This is the lower vertebra. The cement was the cement from the first surgery. It was a pretty hard bone. And this is the coronal view, a little bit unusual. I guess you don't see these images quite often. And this was my Salis procedure. Minimal invasive, took like 75 minutes. Blood loss was minimal, and the patient by herself said it was such a difference. This surgery was so good to be tolerated by her. Even she was now 84 years old. And she said this was really the best surgery of these 3 surgeries she had. So this is the coronal, the AP view, the X-ray, and this was my last case. And I'm happy if you would comment on this.
For the lateral screws and rod, what retractor system do you use to get all that in?
You can see here, this is the standard pedicle screw system. It's a two what is the name? It's CFX. It's cortical finishes. These have got a different. It's the same pedicle screws as I use for pedicle screws. So
that's the same retractor system for a lateral that you normally use.
Yeah, the same retractor. The same retractor. I can skip and angulate it a little bit to cranial. I can angulate a little bit to caudal to insert these screws, and then I mount this the rod, and I tighten the screw heads with the torque, with the anti-torque, and the 80 Newton meters as usual. So when I look back, like 20 years ago, when I started spine surgery as a resident, these lateral approaches were mainly performed in corpectomies and trauma cases. And when we did some A3 or A4 fracture treatments without any injury of the posterior elements, and then this is where the standalone anterior approach was coming from. Later, the companies have introduced some plates with 4 screws on the market, and I would not be able to insert a standalone cage, which is available on the market with integrated screws, because I'm not sure whether I can cement augment them, or do I have to use another Yamashita needle to cement augment them. I don't know whether there are some available in the US or in Australia, but here in Switzerland they are not available. So this is my little bit unusual approach to fix an radiation level in a mild PJK. This is not a severe PJK; it's a mild PJK. I treated several patients conservative without any additional surgery, and this groin pain goes not away, but the intensity of the pain gets better by time when this segment gets different. But this patient, now 84 years old, she said, I don't want to wait until I get rid of this pain, because I know time is running away. So I don't have 15 years or 20 years to live. I want to get rid of this pain. So we decided to do this surgery. But it's elective, and you can compare to this other situation with this decompensation of L3-4 and the bilateral cysts, where there is no meaningful alternative. This additional surgery, this lateral approach, should not harm the patient. So it has to be minimal invasive, it has to be quick without blood loss. And this is what the lateral approach is for me. It's a minimal invasive smart solution, especially for the obese and especially for the elderly patients with osteoporosis. So I don't know whether Mike is still there, but I am sure that he will be presenting next week, and
hey Alex, I'm still here.
Hello, Mike.
Am I on next week? Am I? Excellent.
Your friendly
no,
reminder.
I think we're going to be discussing pediatrics by next week, and I may have a special guest.
Brilliant. That's nice. And you can find all these series and the session of today on YouTube. Dr. Hussein will always put these sessions up 1 or 2 days later. And thank you, and Dr. Andrew Grossbach for joining today. And I'm really, really happy that I will be able to see you here quite more often. So goodbye. Goodbye, everybody.